Welcome to New York Public Health Now, where we talk about the why so you can decide what to do. I'm Dr. Jim McDonald, Commissioner of Health for the New York State Department of Health here in Albany. Joining me today is Joanne Morne, Deputy Commissioner for Health Equity and Human Rights here at the New York State Department of Health. Hello, Joanne.
Hello, Dr. McDonald. Thanks so much for the introduction, and thanks so much for the opportunity. Glad to join you.
Yeah, it's great to have Joanne as our co-host here. Joanne's going to bring her unique perspective and experience in health equity, minority health, and just quite frankly, Joanne's just an interesting person. So I'm always looking forward to hearing what we have to say. I want to just chat a little bit briefly about myself to give some context, maybe some perspective and worldview. So I'm the Commissioner of Health for New York State, but I'm also a pediatrician. I'm also board certified in preventive medicine. My career has taken me many places I did not expect. And funny, I think about my career a little bit like Dr. Seuss might, saying, oh, the people I've met, the places I've gone. Having said that, I went to medical school in Chicago. Since the Navy paid for medical school, I got all over the world, and that was a wonderful experience. I've been in private practice in rural Pennsylvania. I worked with the Indian Health Service and the Navajo Nation in Arizona. Been in rural Tennessee, Rhode Island for over a decade, and here I am in the great state of New York. Joanne, I wonder if I can just now ask you to tell us a little bit about you, if you don't mind.
Yeah, well, you're a hard act to follow, Dr. McDonald. What can I say? I grew up in New York, born and raised in New York, and so I moved from Orange County up to Albany in '91, where I went to a great school, College of St. Rose. Was fortunate to have a great education and worked in the community. I learned early on that community work was really where my heart and my passion is. Public health has always sort of been at the core, though it's interesting, and maybe somewhere in our discussion we'll get to it. I have to tell you, in my early days, I don't think I knew I was doing public health work. But in fact, really, we just looked at ourselves as doing the good work of helping others, right? I came into government about 15 years ago, had the joy of working in the AIDS Institute since then. And since last August, I've been in the Office of Health Equity and Human Rights. So a really great career that has led me to meet some fabulous people and work alongside and on behalf of some really, really incredible communities and individuals. So here I am.
So here you are, and here we are together, and I'm really excited about where we're going to go. So we're in season 1, episode 1 of our new podcast. Why do a podcast is something that I think sometimes people wonder, and yet why is at the core of this podcast? You know, one of the things I'm a big fan of is if people know the why, no matter what it is we're talking about, whether it's public health or quite frankly, how your computer or car works, you have a better idea of deciding what you want to do. So I'd like to explain the why. It's one of the things I find really fun. We're going to be talking about a lot of topics this season: air quality, climate change, opioids, harm reduction. We have a great State Health Lab at Wadsworth. Oh, the places we will go together in public health are going to be fun. But one of the first topics I want to discuss, though, is health equity, diversity. And Joanne, you're more than an expert in this space. And I want to just start with a simple question. You know, what is equity? You know,
equity it's one of these words that we're hearing a lot about lately. I think for those of us who have done public health work or social service work, we've been familiar with this word. But more recently, it's become a word that everyone is talking about. What's interesting about it is that I think almost everyone believes that they understand their meaning as far as when they use the word equity. But the interesting thing is, not everyone shares the same definition. So that can complicate things. If you want a textbook definition, you go to a dictionary, it's going to talk about fairness and it's going to talk about justice. And that's fairness and justice in the way people are treated. For us here in doing the work at the Office of Health Equity and Human Rights and throughout the department, we keep it pretty simple. You know, equity is about ensuring that people have what they need in order to accomplish 3 very key things. And that's survival, the ability to succeed, and then the ability to thrive. Equity looks at opportunity. It looks at resources and networks, supports, making sure that we're doing the due diligence and the hard work so that people have what they need based on where they are and based on where they want to go. How about that? I love the definition. And I think you boiled it down to 3 common sense things. You know, what were those 3 common sense things again? You said things people need. What else was it you said? Well, so it's looking at what people need in order to survive, succeed, and thrive. We don't want everyone to be in a survival mode. We want people to see themselves as able to succeed and continue to advance. And so we want to look at the opportunities to present people with the things they need, where they are at whatever point in life that may be, and where they see themselves wanting to go.
Yeah, and I think about the word thrive that you brought in at the end of that. I think we all want that for all of us. In other words, when I think about thriving, that sounds like I'm growing, it sounds like I'm expanding, but it sounds like I'm happy and I'm having fun. And I want to thrive personally, and I want everybody in New York to thrive, but I'm a global citizen and I'm a global guy. I want the whole planet to thrive.
And that's why you do the work you do.
It is. And, we're a health department, Joanne. And so let's pivot our conversation a little bit to health equity. And part of why I talk about health equity a little bit is that's another term I hear people use. And I think people hear it and think like it's a good thing. But I mean, I've sat across the table from people sometimes, and when they're honest, they say to me like, well, what really is health equity? I mean, can you just tell me what it is? New York State actually went out of their way to actually define health equity in law.
Yes.
Pardon me as I read the law to you. But then maybe after I read the law, you could actually just give us some practical examples of what health equity actually is. Because health equity in the law says it shall mean achieving the highest level of health for all people and shall entail focused efforts to address avoidable inequalities by equalizing those conditions for health for those that have experienced injustices, socioeconomic disadvantages, and systemic disadvantages. Now, it's a bit of a mouthful to read that, but Joanne, you have a wonderful way of taking the complicated and making it simple. Can you give me some simple ideas of what health equity is?
Yes, absolutely. I find in life, but the more simple we can make things, the better it is, right? And honestly, on the serious note, the reason I say that is because what we want people to have is an understanding and an education or awareness so they can make informed decisions. If I were going to offer examples of health equity, it's thinking about how do we ensure access to a service. For some people, they might hear that and they'll say like, okay, so we need to make sure that, let's use an example of dental services, that we have dental services in every zip code. And I would challenge that by saying, well, we can have dental services in every zip code, but does everyone have the opportunity to reach that dental service, assuming it's a brick and mortar location? Is there transportation for the individual? Are there hours that allow the individual to receive services that are accessible? Is language a barrier if there are only English-speaking individuals in that dental service? So those are 3 examples of things that have to be considered around determinants of health that impact access, even when a service is available. Because you'll hear people say all the time, yeah, but there are healthcare services and urgent care centers and emergency rooms all over the New York State. And those of us that do the work specific to equity will say, sure, they're there, but are they reachable for all people?
But can you access them? And I love that you picked dental care, by the way, because I think that's really an important one, because not everybody has dental insurance, by the way. And, it's interesting. Like, that old expression, an apple a day keeps a doctor away? Well, good luck doing that without teeth, right? It's hard to eat an apple without teeth, and you really need healthy teeth in order to eat whole foods, and whole foods are so important, and real foods to actually have a healthy diet. What's another example of health equity? You and I, chat about this sometimes a little bit, because I think, and maybe you could give me a little picture in my mind a little bit about, health equity. Can you give me an example, if you don't mind, of like, maybe it just could be equity in general, like, or equity versus health equity? Just another example, if you don't mind.
Sure. You brought up Apple, so let me give you a visual, if we can do this on a podcast.
I love a visual on a podcast, right. And apples, go for it. It's the Big Apple State, right? Let's hear it. So
depending on the type of podcast player you have, you actually may be able to see an image to help me illustrate the difference between equity and equality. So I want us, and you and I and everybody who's listening, I want you to picture a blank piece of paper. And on that piece of paper, I want you to vision a tree. And that tree is full of apples. And there's a left side, obviously, and a right side. And on the left side, you have 3 individuals of differing heights, maybe someone 6 foot, 5 foot, 4 foot. And then on the right side, you have the same individuals as far as description, differing height, 6 foot, 5 foot, 4 foot. On the left-hand side, someone was gracious enough to buy stools. And everybody got a stool, same height. Individuals climbed up on that stool. They're reaching up to that fruit on the tree. Take a moment and think about what you see. based on what I've described, you're going to see the 6-foot person easily reach the lowest limb and get the apple. The 5-foot person almost can reach the lowest limb, might have to jump to knock the apple down. And the 3rd person, 4 foot, same stool, has absolutely no ability, even if they jump as high as possible, to reach that fruit.
You know, in one way, what I'm hearing you describe here, and I love the visual picture here, but what I'm hearing you talk about is if we help people get what they need, they're going to be able to not just survive, but to thrive, which gets back to what we talked about earlier here. Because, you know, quite frankly, and I think the apple tree is a nice, powerful example. But I think you touched on another word, which was disparities. And oddly enough, New York State legislature have defined what health disparities are as well. And disparities are near and dear to me because I really don't see a reason why a civilized culture should have disparities. But I want to read for you, Joanne, a little bit about what the legislature defined as health disparities because it's a good definition. It says shall mean measurable differences in health status, access to care, and quality of care is determined by race, ethnicity, sexual orientation, gender identity, a preferred language other than English, gender expression, disability status, aging population, immigration status, and socioeconomic status. Again, a bit of a mouthful to be sure. But one of the things I really get to is measurable differences in one group compared to another group. And when you're talking about healthcare, these are what we mean by health disparities. Why are there measurable differences between one group and another group? Because when we really think about it, we're all trying to navigate the same life here. We're all trying to thrive, trying to just get through life here and have a good time doing it. But why should there be measurable differences? So, Joanne, when I talk a little bit about health disparities, what are some of the thoughts that come to your mind about that?
Yeah, there are a lot of thoughts that come to mind, right? Because health disparities are so key. I'm gonna take this word, and I'm not an expert when it comes to data in any way, shape, or form. Anyone who knows me has experienced me in a team setting knows I am a data end user. But there's one thing about data that I always talk about when I do public speaking, and that's the fact that when we look at data, we always have to go below the surface. The initial understanding or the initial presentation of data can lead us off target. And I want to talk about HIV for a moment as an example. In 2014 in New York State felt, and rightfully so based on past accomplishments, that we were in a position to significantly reduce HIV diagnoses. And so a collective plan was put into place, community partnered with government and experts and persons with lived experience, and we've done some incredible work. And if you look at our data, you'll say, wow, New York State absolutely significantly reduced the number of HIV diagnoses based on ending the epidemic planning, partnership, and political will. That's great. But let's start asking the why, and then let's start asking the who. If you look deeper into the data, what you'll find is that there are disparities. So while there were significant reductions across every demographic, some of which you named here or earlier, there still was a disparity in that of the individuals who were still being diagnosed with HIV, those individuals primarily identified as being Black and Hispanic and women. It's really important that when someone presents data, that you start questioning the why and the how and the who, because within the data, there is success, and that's great, but there are lessons to be learned and there is work to be continued. And that, for me, is a great example of disparities. Yeah,
and I think that's really powerful. And we're in our first episode of our new podcast here, and we're talking a little bit about health disparities, talking about health equity, and we're going to just talk a little bit now about another topic called social determinants of health. And Joanne, part of why I think it's important to talk about social determinants of health is one of the things I've been in public health a long time, over 3 decades now. Health disparities, they're all over the place. And one of the things I worry about is that we're used to it and that perhaps we've even become to accept health disparities. Oh, no one wants to admit that. I worry sometimes that we're just used to differences between groups because, quite frankly, as I said earlier, there really shouldn't be differences between groups. So I worry that we're just too comfortable with health disparities because I'm uncomfortable about them. But I want to pivot a little bit to social determinants of health, because the legislature defined this for me as well. It said social determinants of health shall mean life-enhancing resources such as availability of healthful foods, quality housing, economic opportunity, social relationships, transportation, education, and healthcare, whose distribution across populations effectively determines the length and quality of life. Social determinants of health, it's not a new concept. It's not unique to New York. This is something that's a real core public health concept. When I talk about social determinants of health, Joanne, how do we relate that to health disparities?
It's really interesting. I want to make a point that a colleague made to me yesterday. Timing is everything, right? My colleague said to me, if you look back probably about 15 or 20 years ago, there were distinct definitions between health disparities and inequities. If you start to look at literature from then to now, somehow or the other, we have sort of collapsed the two. And the reasons for that certainly could be a podcast in and of themselves. But, health disparities point to, most often, an outcome of not having access to basic determinants of health. And inequities point to some of the more challenging conversations that thankfully, most recently, at least for me in my career time, we've been able to have more open and honest conversations about that are a result of things like structural racism. So when we talk about, and I really appreciate what you're saying, Dr. McDonald, in that we've sort of, just accepted health disparities. It's a part of the work that we do. The persistence of decades and decades of ongoing health disparities that have not shifted at all, except for maybe moments in time, but have not been able to be sustained, is a huge conversation. And it all goes back to determinants of health. If we don't have the basic things we need in order to survive, then we are not going to have the ability, the motivation, or the opportunity to engage in healthcare and in the manner that, we would like to prescribe, right? Annual physicals for an individual who has no insurance, who is feeling quote unquote well, are not going to happen, thus losing the opportunity for prevention. These are huge conversations.
And I think they're important. One of the things I want to do is tie this back to something you just talked about, which was healthcare. Like, I've been a pediatrician over 33 years, which kind of makes me old, but it's okay. but one of the things I think about is I think so much of when I was young becoming a physician, I thought that what was really important was what occurred in the exam room or in the operating room or the emergency room. And those things are important. Yet when I think about what affects someone's overall lifespan, their life trajectory, living free of pain, just living a healthy life, a lot of times it has nothing to do with what occurred in the emergency room, the operating room, or the exam room. It had to occur in their social determinants of health. How was that person's education? Did that person have access to healthy food throughout their life? What were their social relationships? What about transportation? It's the social determinants of health that really do affect people's health and well-being throughout their life. And I want to take this concept and bridge it to the Office of Health, Equity, and Human Rights, which it's a new office in the New York State Department of Health. It's about a year old, right? But can you tell me a little bit about your role leading the Office of Health, Equity, and Human Rights and what you do?
Absolutely. So what we're talking about today is what myself and my colleagues talk about every single day. And I wish I could tell you that out of the outcome of those conversations, we have all the answers, but we don't, which is why, we need to continue to work in partnership, both with community and across the department, to make sure that we continue asking these questions and trying to get to the root of the issue as to why we can't break the historic cycle around these health disparities. The Office of Health, Equity, and Human Rights, we're made up of offices that had existed within the Department of Health, as well as the creation of new offices, 2 that I'll speak of, more to come. The offices that make up this office include the AIDS Institute, longstanding center within the Department of Health, established in 1983, really looking at the prevention, treatment, education, and outreach related to sexual health, as well as looking at the opportunities in which we can provide service access and care for individuals who use drugs, and definitely at the core of our work, working in partnership with the LGBTQ community in order for us to look at health and wellness and the promotion of that. The Office of Minority Health and Health Disparities Prevention, again, another longstanding office here at the department, doing some incredible work in partnership with nations across New York State, as well as looking at, in what is, in my opinion, another social determinant of health, language access. Trying to ensure that all of the services in New York State and across the department really are prioritizing language access, both interpretation and translation for individuals. We have the Office of Gun Violence Prevention, a fairly new office still, just over a year old, that was established with the intention of looking at gun violence prevention through a public health set of principles. And also, I'll talk about the two new offices, Office of Diversity, Equity, and Inclusion, in order for us to look at our workforce and the opportunities we have there, and a most recent office of Health Equity Impact Assessment, established to support a recently legislated law that looks at the Certificate of Need process and the requirement of health equity assessment to determine impacts on communities when changes are proposed.
You know, Joanne, one of the things you remind me about is something I say at the New York State Department of Health a lot is, if I just listened to what you were talking about, I kept hearing the words health equity, diversity, inclusion. And one of the things I say around the department a lot is, folks, we're a health equity organization that happens to do public health.
Yes.
And part of why I say it that way is, I'm really well aware that there's other state agencies that have core public health missions, public health functions. There's other entities outside of state government that do public health as well. Certainly in Department of Health, we don't have the corner on the market of public health. In fact, I think public health is largely public. So a lot of what we do is point us all in the right direction and do what we can. One of the things you did mention, you talked about your work with nations, and I'm not sure that everyone understands the word nations. What did you mean by working with nations?
In New York State, we have 9 nations across the state, and individuals where Native Americans often reside. It's really important. A lot of times when you go to public events, you will hear the start of that event begin with a recognition of the fact that we stand on the land of Native Americans. And, this declaration and public statement is one that is of due respect, understanding the history. Interestingly, as we talk about equity and we talk about access and we talk about what drives inequities, we certainly can point to much of history there. The department has some very intentional and important work that is done with individuals from the nations in ensuring that there is access to healthcare. And so we have an American Indian Health Program, as well as other programs that help promote our partnership as well as our future planning, recognizing that disparities also absolutely are represented within these areas and communities, and pointing to the fact that we have a lot of work to do in our understanding of the needs and in our ability to respond effectively. Yeah,
thank you, Joanne. And as our first episode comes to a close, I think as a listener, you're realizing there's a lot that goes on at the New York State Department of Health. We've talked a lot about equity, health equity, social determinants of health, and we've talked a lot about health disparities, all important topics. But when I get back to the why we started this podcast, it's so you can understand the why, and it can help you decide what to do. And I'm hoping after listening to today's episode, you're thinking like, I understand why the New York State Department of Health wants to do a podcast, and I'm hoping you'll decide to join us and subscribe to our podcast and listen to us talk about this and other interesting topics as we go throughout our time together. So if you have an idea for topics we should talk about, please let us know by email at publichealthnowpodcast@health.ny.gov. So that's publichealthnowpodcast@health.ny.gov. Please do keep an eye out for New York Public Health Now on your favorite podcast platforms like iTunes, Spotify, YouTube, and Google Podcasts. And tap the subscribe button to be notified when a new episode drops. To easily find us, search for our podcast titled New York Public Health Now, or by keyword NYSDOH. I'm Dr. Jim McDonald, Commissioner of the New York State Department of Health.
And I'm Joanne Morne, Deputy Commissioner for the Office of Health Equity and Human Rights.
Thank you. Have a good and keep up the great.